All right, let's dive right into this explainer. Today we're decoding one of the absolutely most critical structural systems in our bodies. And we're going to look at exactly what happens when its very architecture starts to collapse due to COPD, or Chronic Obstructive Pulmonary Disease. You know, this isn't just about a persistent cough. It's a really fascinating look at microscopic mechanics and total structural failure. To make this complex topic easy to grasp, here is our blueprint for today. 1. The healthy respiratory system. 2. Understanding the COPD spectrum. 3. The twin pillars of COPD. 4. Clinical phenotypes A and B. 5. Diagnosis and gold staging. And finally, 6. Stepwise treatment and management.
Section 1. The healthy respiratory system, setting the baseline.
Think of the lungs kind of like an architectural blueprint. Every single breath we take completely relies on this healthy structural anatomy. Air travels down the trachea, splits seamlessly into the right and left lungs, and is pulled in by the mechanical drop of the diaphragm, which expands the chest cavity. When it works, it's a perfect machine that keeps us alive and well oxygenated.
So the absolute key to making this whole system work is a fundamental concept called the ventilation-perfusion, or VQ ratio. Now, what does that actually mean? It simply means that for our lungs to do their job, the incoming air, that's the ventilation, must perfectly match up with the blood flow, the perfusion. If either one of these gets out of sync, the whole system really starts to suffer. If we zoom way into the microscopic respiratory exchange unit, we see this delicate mechanism in action. Gases are dynamically diffusing from areas of higher pressure to lower pressure right across a miraculously thin, semi-permeable alveolar capillary membrane. But right here is the major vulnerability. Any thickening or inflammation to this barrier instantly impairs that oxygen transfer, and that leads to hypoxemia, which is dangerously low oxygen levels in the blood. Moving on to Section 2, understanding the COPD spectrum, the breakdown.
So, COPD is ultimately characterized by an irreversible obstruction to airflow throughout the lungs. But clinically speaking, it's not just one single isolated condition. It's actually a sliding spectrum. On one far end, we've got pure chronic bronchitis, and on the exact opposite end, pure emphysema. In the real world, most patients are going to fall somewhere right in the middle, showing features of both.
But honestly, regardless of where a patient sits on that spectrum, left, right, or dead center, the clinical reality and the defining hallmark of COPD is a pathological trapping of air. The lungs become obstructed and the patient simply cannot exhale fully. It's literally trapped inside.
All right, Section 3, the twin pillars of COPD, anatomical locus of disease.
Let's really contrast those two pillars. Chronic bronchitis is strictly an airway problem. It's driven by physical blockages in the bronchial tubes, mostly due to severe mucosal edema, inflammation, and just a massive overproduction of mucus. Emphysema, on the other hand, is an alveolar problem. This is a structural breakdown at the very end of the line. The tiny alveolar sacs themselves are destroyed. They lose their elastic snap, and they end up trapping air deep inside the lungs.
So, what actually triggers all this destruction? Well, cigarette smoke and heavy industrial pollutants are the massive obvious culprits driving inflammation and oxidant injury. But surprisingly, there's also a genetic trigger, alpha-1 antitrypsin deficiency. It's a genetic anomaly that disrupts protective proteins, which leaves the lungs completely defenseless against their own enzymes. And crazy enough, this can cause massive structural degradation and emphysema in young adults who have literally never touched a cigarette in their entire lives. Which brings us to Section 4, clinical phenotypes, A and B.
Because these two twin pillars damage the respiratory anatomy so differently, they actually show up in patients as a textbook clinical dichotomy. Type A patients, who are often called pink puffers, are battling emphysema. They suffer severe breathlessness, struggling to exhale, but they generally maintain a pinkish complexion. Then we have Type B patients, the blue bloaters, who are dominated by severe chronic bronchitis. They struggle with copious amounts of purulent sputum, and because of chronic low oxygen, they frequently develop cyanosis, which is a bluish tint, alongside right-sided heart failure, known as cor pulmonale.
Section 5, Diagnosis and Gold Staging.
Once a clinician recognizes one of these phenotypes, they have to objectively measure the extent of the airflow obstruction. And this brings us to the GOLD criteria, which acts kind of like a dashboard for disease progression. The absolute anchor for a COPD diagnosis is a very specific breathing ratio. The forced expiratory volume in 1 second, or FEV1, divided by the total forced vital capacity, or FVC, must be less than 0.7. Once we have that confirmed, then we look at severity.
Now, severity is purely dictated by that FEV1 metric, basically how much air a patient can physically force out in 1 second. Just look at the sheer drop-off here. As lung capacity plummets from 80% in stage 1 all the way down to below 30% in stage 4, the patient slides from just managing mild symptoms into highly dangerous, life-threatening respiratory failure.
Finally, Section 6, Stepwise Treatment and Management.
To combat this escalating loss of lung function, treatment for COPD is highly structured and stepwise. It absolutely always begins with Step 1, baseline mitigation. That primarily means removing irritants through smoking cessation. From there, as the disease progresses, we step it up to maintenance inhalers to keep the airways open. Then we introduce powerful steroids and antibiotics for flare-ups, and ultimately, we have to rely on surgical or life support measures.
Drilling down a bit into the specific medications, bronchodilators like salbutamol provide vital, first-line symptom relief by simply relaxing the airway muscles. But when patients face severe acute exacerbations, which are very often triggered by bacterial infections, it demands an immediate escalation. We have to deploy antibiotics like oxytetracycline or ampicillin right away to target that bacterial load and prevent total respiratory failure.
Now, for end-stage, stage 4 patients, those standard medications are just no longer enough. The final defensive line involves domiciliary oxygen therapy, and this is tricky. It must be precisely monitored at low concentrations so we don't accidentally suppress the patient's natural drive to breathe. Alternatively, we use highly invasive surgical salvage options like a bulectomy. This involves physically resecting massive, dead, hyperinflated air spaces just to allow whatever healthy lung and diaphragm tissue remains enough room to function.
To wrap up this explainer, I really want to leave you with a critical thought. We've seen the architectural blueprint of the lungs, and we've seen how emphysema and bronchitis systematically destroy it. Knowing that this structural breakdown and alveolar hyperinflation is completely irreversible, meaning we can only manage it, we can never actually cure it, how does understanding this anatomy fundamentally change our urgency around early intervention and smoking cessation? Think about it.